Good afternoon and welcome. Last year, your Office of Alumni Relations created a space to guide and embrace our newest alumni since our traditions in welcoming the newest graduating class were paused. As we gingerly move through our present time, the From Pause to Clause Alumni Speaker Series remains relevant. Today, we will have another moment of receiving knowledge, and we look forward to your attendance in the months of February and March as we expound on other pertinent topics. Each theme supports and strengthens the knowledge base of our current students, recent alumni, those who have worn the badge and honor as alumni for years, and friends of Clark Atlanta University. Furthermore, we wish to thank the alumni panelists from last year and those presenting today. We did not seek you out, yet you came with the spirit of a mighty panther, which we are, sharing your awareness and expertise when the call to participate went forth. Before we move into today's discussion, let me share a tad bit of history on the Office of Alumni Relations signature event. The Alumni Student Networking event was originally designed in 2008 when Kareem Taylor, class of 2010, in his sophomore year, expressed that students should be engaged and learn from alumni of our one exceptional university. Over the years, we continuously call on members of the alumni community to embrace our alumni in waiting, commonly known as students. We encircle them until they become a member of our alma mater. As Panther Cubs, they develop through discovery, academically, socially, and spiritually, finding their way as their paws grow claws and become fully entrenched felines of service locally, nationally, and globally, while remembering to provide financial support to the institution that placed them on their path as well-rounded citizens. There is more to this program and events which can be found on the CAU website. And speaking of financial support, we are presently halfway over our 1 million alumni giving goal for this fiscal year. Look for additional information on how to share your heart with CAU during the month of February. As we begin our exchange on this day, I would like to express thanks to my colleague, Chastity B. Evans, class of 2010, who serves as the program manager in the Office of Alumni Relations. She will be your host, for she created this space for our interaction. Chastity, it is now time for you to begin our conversation.
I think someone was muting me. Sorry. Well, thank you so much, Alumna Gaylani Gatewood Joshua, for that treasured introduction and credible context. Welcome, everyone, and thank you all for joining us, the Office of Alumni Relations, for our webinar series, Protecting Our People's Health and Well-Being, Opportunities and Obstacles for People of Color in the Medical Field. An exceptional thank you to alumna Dr. Michelle Rhodes, Program Specialist for the Office of Online Learning and Continuing Education, for being the technical guru behind all of OAR's webinars. Let's go a little bit into the purpose so you can understand what we're talking about today. Stigma, inequities, and civil rights injustices remain in our society today. Unfortunately, skin color plays a large part in how people are viewed, valued, and treated. We know that racism, both intentional and unintentional, affects the health and well-being of individuals and communities and stifles the opportunity of many to contribute fully to the future and the growth of this nation. Join your Office of Alumni Relations today to discuss racism's impact on health and disparities in the medical field. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the Q&A box in your Zoom control panel. I will bring them up during our Q&A session to discuss. Now, without further ado, introducing our first panelist for this afternoon is alumna Sandra Brooks. Alumna Sandra Brooks is the owner of PYP Consulting and SG Bede. She received her bachelor's degree in business administration from then Clark College and a master's in quantitative economics from Atlanta University, and has over 30 years of experience working in healthcare, strategic planning, project development, and research. Early in her career, she focused on research with a special interest measuring the impact of social programs on minority communities. Alumna Brooks moved to administration positions where she could have a direct impact on pediatric healthcare and safety net hospitals. In 2017, she made the leap to full-time entrepreneur by revamping her consulting company and starting an online retail jewelry shop. She is strongly committed to Clark Atlanta University and volunteers with the CAU-AA Incorporated, the CAU Guild, and the CAU-AA DeKalb chapter. In addition, she is a long-term member of Cascade United Methodist Church and the DeKalb Chamber of Commerce. The pandemic has kept her away from the campus, but she is grateful for the opportunity to virtually connect with students and alumni. Thank you so much, Alumna Brooks, today for joining us and for always serving your alma mater. How are you doing today?
I apologize for that. Thank you so much for having me. I am doing well.
Awesome, awesome. No problem at all. No problem at all. Well, we're going to go into your first question for today. Being a part of the healthcare system for over 20 years, have you noticed potential increases in racial inequities for both physical and mental health outcomes?
Great question. Thank you.
Thank you.
I can think we all can agree that racial inequalities and physical and mental health have existed since our ancestors reached the shores of America. While we have seen progress in some areas of health outcomes, there continues to be factors beyond socioeconomic status, race, and ethnicity that prevent us from being on par with whites. We can broadly measure racial inequalities in healthcare as lack of adequate access to health coverage, lack of access to practitioners, communication between physician and patients, physician stereotyping, and cultural insensitivity. All of these inequalities have led to some alarming outcomes. When we look at the Affordable Care Act and what President Obama did, he lowered the number of Blacks without insurance to an all-time low of 10.7%. But when our former president, Donald Trump, amended the program, we saw that rate go back up to 11.7%. In 2019, Blacks were 13.4% of the population, but only 5% of active physicians. And in the same year, 7.3% of students enrolled in medical school were Black. We still aren't on par. Black women are 3 times more likely than whites to have low birth weights. 42% of new HIV cases are Blacks. And are Blacks. So what I would like to say also, there are climate changes, there are environmental injustices. There are so many things that impact us. When we look at climate change and environmental health and justice, we do not have access to recreational activities in our communities. We have the food deserts that exist. We're next to landfills, more air pollution. We have water pollution. So all of these things that we really we can't control, or we're greatly more impacted in our communities. Even the beauty industry, we have campaigns that target us with things that are hazardous materials, carcinogens. We hear things about hair relaxers, hair dyes, even the acrylic nails, all known carcinogens to Black women. But tobacco and alcohol industry have been out in the minority. So I would say in a nutshell, yes, the racial injustices and inequalities exist. a lot of work to do. The rate of increase, I don't see it going away. I see it staying not stable, but it's going to keep changing. So therefore, we have to keep our eyes open at all times.
Exactly. Wow. I mean, that's definitely a lot to think about. And who knows that all of it definitely would tie to your health. So, well, do you sense that racism is a driving force for the social determinants of health in the Black community? Like, how can we go about dismantling this system?
Well, I think to keep it like we do in our church, let me give you 3 points. So to keep it simple and plain, first thing we need to do is educate. We need to start education even in our college courses. Not a full-time class, but students need to understand about public health at an early age and its importance to themselves. So we need to educate, really understand the outcomes that we need to be working on, and also realize that it's not a dynamic field, that it's a dynamic field, but changes are constantly going to come. For instance, the impact of COVID-19, we all know that. We always see the death rates for Blacks are higher, but what are the long-term effects? What are some of the things that we need to be considering for the next 10 years? What happened to children who had to stay home? What happened to children who lost access to food? So those are some of the things that we need to start working on. We need to train more people to be physicians, social workers, psychologists, counselors, epidemiologists, and on and on and on. We need to do education. We need to strategize, come up with more outcomes that will impact short-term and long-term solutions. I think the virtual world is wonderful. We need to fully utilize it right now and get the most out of it. And finally, we need to advocate. If we, even in the election box, if your leaders in the community, whether federal, state, local, are not supporting you, we need to address that and realize that we need them here. We need to bring our concerns to them, and we need to go to our families. We don't talk to our families enough. We need to tell Big Mama, while I love you, and I know you don't go to the doctor, it's important to me. It's important to our heritage. It's important to our family. So I think educate, strategize, and advocate. That's some of the ways we can remove it.
Oh, yes. Yes, I love that. Thank you so much, Alumna Brooks. I mean,
you're welcome.
Thank you for the helpful information and the astuteness. I mean, we truly appreciate that. If you all have any questions for Alumna Brooks, please type them into the Q&A box in your Zoom control panel now, and we'll be sure to get to them during our Q&A session. Thank you again, Alumna Brooks. Introducing our next panelist for this afternoon is Alumna Dr. Ayanna S. Kirksey McMullen. Alumna Dr. Kirksey McMullen is a board-certified physician who specializes in physical medicine and rehabilitation and osteopathic medicine. A proud alumna of Clark Atlanta University, she also earned a master's degree in the field of health policy and administration from the University of North Carolina at Chapel Hill. Her medical degree from the University of Medicine and Dentistry of New Jersey, and completed her medical residency at the Johns Hopkins University Hospital, where she also received the Hopkins Healer Award for excellent and compassionate delivery of care. Alumna Dr. Kirksey McMullen is published in the areas of public health and physical medicine and rehabilitation, and has appeared in Men's Magazine and Happify.com as a guest contributor. She is the owner/operator of ASKM Enterprises, LLC, a health and wellness consulting company, as well as the medical director for the stroke program at Good Shepherd Rehabilitation Hospital. Thank you so much, Dr. Kirksey McMullen, for definitely joining us. We truly appreciate all that you're doing out in the community, and thank you again for serving your alma mater. How are you doing today?
I'm doing well. Thank you for having me. I'm so excited to be here today.
Awesome.
I love my alma mater, so I'm really excited to be here.
And we are so excited to finally have you and hear what you have to say. So we're going to go into your first question for today. Given your experience as the medical director for the stroke program at the Good Shepherd Rehabilitation Hospital, Can you speak to how disparities in health and healthcare is reflected in major chronic disease such as stroke, and how these disparities might inform priorities for addressing health outcomes?
Absolutely, sure. Alumna Sandra also spoke to some of these things as well, but certainly we have made some progress as it pertains to chronic diseases and social determinants of health. If we look at things like infant mortality or educational attainment, or even in life expectancy. So if we tease out life expectancy, and let's say we look at the expectancy of life for African Americans in the late 1960s and compare that to where we are right now, we actually have had about an 11.5 year increase in the lifespan of African Americans. And that's great. But we also have to put that in context, right? Because if we look at our white counterparts, we still see that there's a pretty big disparity in terms of life expectancy. So let me make it concrete. If we look at white females, they are expected to live approximately 80.5 years of life compared to African American women who have a life expectancy of about 76.1 years. Then if we compare white men who then have a life expectancy of about 75.3 years, and then compare that to African American men whose life expectancy is about 69 years. So we're not even looking for them to live into their 70s when we're looking at them in aggregate. So for the entire population, there's about a 3.5 to 4 year difference for African Americans in terms of life expectancy. And that is really problematic, right? Especially when we line that up with other things that we know in terms of health outcomes. So right now, prior to COVID-19, the top 5 causes of death included cancer, heart disease, lung disease, stroke. Now with COVID-19, the top 3 are heart disease, still cancer, COVID-19, and stroke. But when we look specifically at African Americans, we know that African Americans are twice as likely to die of all causes of death at an early age. Let me repeat that. We are more likely to die at a younger age of all causes of death. Okay. Now, we also want to couch that with the understanding that African Americans are 50% more likely to also experience heart disease and hypertension. And heart disease and hypertension obviously puts us at higher risk of having things like heart attack and stroke. And then we also couch that next to the understanding that African Americans are much more likely to experience stroke. In fact, 2 times more likely to experience stroke as we look at our white counterparts or even other people of color. So when we talk about priorities on addressing issues of health disparity, I think it's important that we really continue to have these transparent conversations about the statistics, but also why do these statistics continue to prevail, right? Alumna Sandra also talked about advocacy, and I think that that is extraordinarily important. I'm of the mindset, though, that we have to address that from a number of different angles. As voters, as being part of the American system, we have to hold our policymakers responsible, right? So that's on a national level that we are engaging people who are creating policy. Mm-hmm. We also are engaging people on the state level. What a lot of people don't realize is policy is set on the national level, but how that's actually translated into practice happens on the state level. So then you need to engage your governor and you need to engage your state level politicians as it relates to health disparities. But I believe that the greatest work, and there's plenty of evidence to support this, the greatest work happens on the community level. It happens on the local level. And that means that all of us have to decide to be engaged in creating solutions for ourselves. If we continue to wait on the federal government or the state level government to create these solutions when we have access to this information, and I personally believe the genius that we need in order to create those solutions are firmly seated in the bosom of our community. So we don't have to wait for that. And we see examples of how we have been able to implement that over time. We see it in the civil rights movement. I think a very simple but very elegant example of how we were able to identify a public health and a health crisis and create a solution is that of the Black Panthers. So in the late 60s and 70s, the Black Panthers saw that children were unable to concentrate in school. Black and brown children were unable to concentrate on their education because they were hungry, right? And so what did they do? They pulled resources together and they created a free breakfast, a hot breakfast program for our children so that when they went to school, they were not hungry. That is elegant in its simplicity, right? And it required no one else to make that happen. And in fact, the free breakfast program and free lunch programs that we see today in the public school systems are based off of what we saw in the Black Panther Party. Nobody talks about that because of the controversial elements of, or what people might perceive to be the controversial elements of the Black Panther Party. But that is a beautiful example of when we take a problem and we create a solution for ourselves. So I believe it most powerfully rests with us.
Well, how does racism, in your opinion, impede progress towards public health goals? Like from the groundbreaking Heckler Report, which detailed stark disparities and leading causes of death between racial and ethnic minorities, to healthy people objectives and leading health indicators.
Okay. And again, alumna Sandra really spoke to a lot of this as well. I just want to kind of give people a background of the Heckler Report and Healthy People 2020. So the Heckler Report came out of the task force for the Office of Minority Health through Health and Human Services around the mid 1980s. And the point of the Heckler Report was to try to quantify and qualify disparities of health and what interventions were already being done to try to address that, because there was a disproportionate amount of deaths and sickness in people of color compared to white counterparts. And around the 1990s, the Healthy People Initiative was rolled out by Health and Human Services, so the same organization that did this report, setting an agenda that is supposed to change every 10 years. So it started in 1990, now we're at Healthy People 2030. So certainly we have made some important gains in terms of identifying the trends and trying to start to create some solutions around the problems that we're seeing in terms of disparity in the Black community. However, unfortunately, we have not made tremendous gains in talking about and clearly identifying racism as a public health threat. In fact, it's only been since 2020 that the American Medical Association actually identified racism as a public health issue that we need to address. And that is not just a public health issue on the individual level, on the community level, but it is an outcome of systematic racism. And because of that systematic racism, we're not going to be able to move past some of these issues until those things have been addressed, right? So in order for us to be able to fully address issues of disparity in our communities, we then have to at least be willing to have this conversation. And as long as we continue to skirt over it, and when I say we, I mean Americans, continue to skirt over this issue and avoid it in a holistic way, then we can't make the systemic changes, or at least we will make it will be more difficult for us to make the systemic changes. Maybe not on a community level, but certainly on the systemic changes, because the reality that racism is a public health issue and it affects every dimension of health. If we understand that health is physical, it is spiritual, it is emotional, it is environmental, it is economic, right? And it shows up not just in the outcomes that we're seeing for African Americans in terms of their health, but it also shows up when people of color, providers of color, whether they are clinical providers, public health providers, administrative providers, are out in the community and trying to make impactful changes, and they are encountering people in the community and our colleagues who question our credentials, who question our right to be there, who question whether or not we have the ability to actually speak to these things in meaningful ways and powerful ways. And I think that has really shown up a very acute way of looking at it is in the case of Dr. Susan Moore, who recently passed away from the complications of COVID-19 after receiving suboptimal care in the healthcare system that she went to receive care. And she was posting about the people ignoring her complaints and so on and so forth and being discharged early. And unfortunately, this woman, who was a family medicine physician, died of the complications of COVID-19 very soon after going into another hospital for readmission. The reason why I'm bringing this up is because when this woman died and her family posted some of these things to make people aware of what happened, the CEO of the hospital that she first was admitted to made a comment that part of the reason why she had the experience that she had is because she was a complex patient who was intimidating the staff. What does that have to do with anything? Those kind of comments are steeped in racism. They're steeped in pejorative ideas about Black women as angry Black women, as you know, that is couched in the sapphire caricatures from the Jim Crow era. And that shows up even as we're trying to do our jobs. So if we're going to have a conversation about this, we have to be real about what's really happening here and not be afraid to speak truth to power.
Exactly. I definitely smell a part too. You smell one, Dr. Carson McCullen? You smell it?
Yes, ma'am.
Is it in your lungs?
It might be deep down in my lungs.
Good. Because prepare for the phone call. Thanks. Thank you so much, alumna Dr. Carson McMullen, for the essential tips, the materials, and the super helpful advice. I mean, yeah, you and Ms. Brooks, y'all done brought it. So we got to see what's up next with alumna Dr. Jackson. So if you all have any questions for Dr. Carson McMullen, please type them into the Q&A box in your Zoom control panel now, and we'll be sure to get to them during our Q&A session. Thank you again, Dr. Carson McMullen. We truly appreciate everything. Thank you. Introducing our next panelist is alumna Dr. Tatiani Jackson. Alumna Dr. Jackson is a double-boarded breast imaging and nuclear medicine radiologist at Geisinger, Wyoming Valley in Wilkes-Barre, Pennsylvania. She completed her MD at the University of Autónoma Guadalajara in 2009, residencies at Stanford University Medical Center in 2015, and Boston University Medical Center in 2019, respectively, for nuclear medicine and diagnostic radiology. Lastly, she obtained her fellowship training in breast imaging at Beth Israel Lahey Health in 2020. Her passions are promoting diversity and inclusion across the field of medicine, particularly in the areas of equitable healthcare and research in marginalized populations. Thank you so much, Dr. Jackson, for answering my calls, emails. I truly appreciate you for being here today and for telling us all of the good stuff that we need to hear about our health. How are you doing?
I'm doing fantastic. Thanks for inviting me, and I'm honored to be here.
Awesome. We're going to go into your first question for today as well. So 30% of African Americans believe that their health is dependent upon faith or destiny, and only about 50% feel that health is a high priority. As a breast imaging and nuclear medicine radiologist, do you think African Americans receive the proper services needed to overcome obstacles and create new opportunities? And I think, alumna Dr. Kirksey kind of touched base on this just a little while ago regarding the example with the family practices, doctor. So, have you seen any of that?
I have seen it, and I agree that the fact that 30% of African Americans believe that their fate is just dependent on luck.
Yeah.
Is astounding, and we should all think about that and try to do everything that we can to change it. And I think that a lot of the many things that are getting in the way, or the obstacles that create these lack of opportunities, I say the most important thing has been access. And just like Dr. Kersey McMullen mentioned, it's racism, systemic racism, it's redlining. I can speak for the state of Massachusetts, where redlining is very big, and it's drawn out in obvious lines where you have African American and Latino, and even certain Asian populations like Vietnamese and Koreans that are limited to areas of Boston, of the city. And then when they have to to commute to these hospitals that provide astounding care, it takes multiple buses, multiple trains. It snows in New England. It's 12 degrees outside right now. Like, you're not going to go to your doctor's appointment if you have to stand outside and wait for a bus that comes every hour. Another thing that's really, really been bad with access is gentrification. So now you have people that are spending top dollar in these communities that are in the city, that are surrounding these very high-end hospitals that have been rated best hospitals in America, but they're booted out of their homes because they can't afford to live there anymore. So now if you're raising, like, let's say, you're making, what are we making for African Americans? It's common like $40,000 a year for maybe a family of 4 or 5. And now your rent goes up to $3,000, you can't afford that. So now you may not have a car, so you're dealing with public transportation. So now you're being moved out of the city into bordering neighborhoods like, for example, Brockton, or anything like outside of the city of Atlanta, or outside of whatever major city where these hospitals are. And you have that one shuttle bus that comes every 2 hours. So it's like, you can't get to these appointments. So access is very, very important. And then the cost of care. Again, like many of the previous speakers mentioned, you have to have healthcare insurance. The Affordable Care Act helped that a lot, where what I noticed when Obama was in office is that we did see a lot of African Americans, Latino, and other minorities coming to their appointments, just saying, oh, we just got insurance. This is why I couldn't show up to the doctor's appointment, but I'm here now. But you're catching things late, So then there's the stigma that's been ingrained in medicine, which is horrible. And there was an article published in the New England Journal of Medicine. I'll put the name in the comment boxes right now, it eludes me, but they discussed how it's taught to you in medicine. Like, they tell you facts without giving you reason of facts, like sickle cell disease. Why are more African Americans prone to sickle cell disease? They just say because they're Black. But they don't say that if you live in Africa, where there is malaria, and it's just it's Darwinism. It's the process of who lives. Your blood mutates. Your blood mutates for you to survive in Africa, where there is malaria, and that is your African ancestry. So then that's passed on to you during the transatlantic slave trade, where now African Americans who end up here in America against their will, they have these traits, and it doesn't make them more prone to certain cancers and certain blood diseases, but it's not obviously just because they're Black. Right? There's a reason. So you should teach them, when you're teaching in medicine, like, what is the background of these diseases and how do we treat them? There was another point that they raised in this article, that when they're talking about hypertension, they teach medical students that, okay, when you're dealing with an African American, these are the medications that you start them with, because this is what they tolerate. But, these can be the second line medications in reference to your white counterpart, because they tolerate it differently. But why is that, right? They say because of the salt sensitivity and other things, but they don't really give you any history. So I think also in that access, it's education. And the bias, and that all that shows a huge bias, which is all related to racism. Like, there's no other word that you can use for it. And I think all that creates obstacles. And then obviously this prior speakers mentioned several other things that, I mean, I don't need to repeat because I mean, it's so pervasive, like how can you forget what they said? Like everything that is in medicine, unfortunately, even with medical apartheid and pain management, right? So they think that African Americans experience less pain. So if you're gonna go to the hospital and you know you're in pain and you know they're not gonna treat you for it, you're gonna bear it out at home. You could be at home with a perforated appendix, and then by the time I see you, you know, in my head, it's like, why didn't they come, right? So then you're thinking like, you know, for me, I'm thinking of what are the barriers? But for my white counterpart, it can be like, oh, they just don't care, right? Like, so like what I see is different from what they see. And if they ask me a question, I do my part in educating them as like, no, these are the factors of why people don't show up. It's not that they don't care, but if they're not going to get proper care, why would you come to a hospital?
Exactly. Wow. I mean, you just literally just blew my mind. Like seriously. I mean, even all the way down to the blood pressure, you know, medicines. I mean, that's wild.
Yeah. I mean, so a lot of physicians now and medical schools are trying to revamp their education, but it took George Floyd to die for this to happen. Like, I feel like I wasn't, you know, I'm new coming out of medicine. You know, a lot of the women on this phone call have had years of experience. So I've seen this, and now I can see the strike transition and now how they want to approach it when it was things that this was happening to us 400 years ago, but now you see it on your phone, and we've been seeing it on our phone, but you actually had to see someone killed on the phone and it be blasted during this very tumultuous time with former President Trump being in office, that people started to realize like, this man's a demagogue and these things are really happening to African Americans and now we need to address it. And I mean, I feel like this kind of motion that is happening needs to persist, and we need to get more allies that can help with the fight, because we all can do what we can, but at the same time, like, this is a predominantly white culture and they need to do their part.
Well, the overall incidence for cancers, you know, they rates among African American women is not the highest among ethnic groups, but the death rate is. So with breast cancer being the health disparity, what are some ways more women of color can take advantage of the better radiological services that are meeting or exceeding the highest level of standards in the radiology field? Like, what can we do in order to kind of halt, you know, this death rate, although we're not the prime people that are catching it, that are attaining these cells?
So I just want to give you some facts on what we do know in medicine about the death rates in African Americans. So the American Cancer Society noted that the death rates in African American women are 39% higher than the death rates in white women. We are more likely to present with triple negative breast cancer. For those who don't know what triple negative is, there are 3 receptors that come with breast cancer that an oncologist can use to personalize your care. That is ER positive, which is estrogen, progesterone positive, and HER2 new positive. So then you have a medication to target each one of these receptors. So when you present with triple negative, meaning that the medications they have do not target any of these receptors, now you're stuck with a slew of chemotherapeutic agents, radiation, and most likely not surgery, because triple negative cancers are prone to present with metastasis. So you're already at an advantage when you present with triple negative breast cancer, and it's commonly seen in young women. And when I say young, I've seen cases of them being in women at 28. They do survive, but if you get cancer at 28, your progression-free survival rate, if you're expected to live, I don't know, let's say you live until 85, like it's low. Mm-hmm. And then there's also the instance that of African descent, just like the sickle cell or having sickle cell trait being of African descent, we are at 6.9% higher rate of carrying a BRCA positive gene. Outside of Ashkenazi Jews, who are higher than that, this rate is higher than our white counterpart. So this is another thing that a lot of African-American women do not know, is that if you carry the BRCA gene, which is the breast cancer gene, and you have it, depending on which one, there's a BRCA1, there's a BRCA2. If you have BRCA1, you're 65% more likely to get breast cancer versus BRCA2, where you're around, I think, 13 to 25%. And this is also in men. So men, Black men can also carry the BRCA gene, and they can pass that on to their daughters and their sons. So if your father has it, obviously you should get genetic testing, because that can be passed along to you as well. So I think the effort needs to be both on the clinician's part as well as the, as well as the population. And some of the things that we can do as doctors is to start educating women at younger ages about the risk of breast cancer and breast health. Just, knowing your breasts, knowing how well they feel. I know that they say, and there's been a lot of studies, that self-breast exams are biased because you feel a lump, it could be tissue, but still the fact that you know what they feel like, so when you actually do feel something different, you know to talk about it. Another important thing that more doctors need to do on our end is more community outreach, going to churches, going to those community healthcare centers in your local neighborhood and speaking during Breast Cancer Awareness Month, and getting women there and educating them as to why breast mammograms are important, and why do we do compression, right? Because everyone's just like, I hate getting a mammogram because they squeeze my breast like a pancake. You don't know how many times I hear the pancake thing. And, so then when I tell them that we have to do compression because it, one, reduces the amount of radiation that we give to you, it makes our images better because we can see through the breast tissue. And it also makes you stay still, because motion with imaging is, is counterintuitive. So you have motion, you can't really see anything, and then we have to call you back. And then it reduces the reasons that we have to bring you back to get a mammogram. If you allow us to do the compression, you stay still, and we do tomo. So then when you tell them that, then they're like, oh, so if I stay still, most likely I won't have to come back. And they're like, yes, they love it. They're like, okay, I get it. I'll just suck it up. We can do, women have children. You can take 10 minutes of doing a mammogram once a year. And then another thing, like I said, is just addressing the biases in medicine. So again, just like what Dr. Kirtsey McMullen said, is that there's labels that are given to patients. And I can just give you examples. Like when I'm in clinic, my workflow is that when you come back for your mammogram, we do additional views. So I look at those views, and if the area that I'm concerned about is still there, then you automatically go and get an ultrasound. And an ultrasound just allows us to use the ultrasound waves to see through the breast tissue to see if we can locate that area of concern to a quadrant. So we talk to the ultrasound tech, we tell the tech what we want, tech takes the patient back, she does the ultrasound and comes back and presents the images. And they always tell you the demeanor of the patient. So you know where I'm going here. So whenever, I'll just say, like, how is she? Because I just want to know if the patient's anxious, so then I know how I need to prepare my conversation as I'm walking there. Like, how do I need to address them? Should I sit by her side? Should I sit in front of her? Because some patients don't like you to invade their personal space, and some care, like they want you there. So you just need to know, so you know that you don't walk in there, to something where you don't know how to address the situation. And I'd say, without a doubt, if it's a Black woman, they say she's upset, or she's angry, she's not being pleasant. And then when it's a white woman, she's anxious, she's worried, she's concerned, I think she's going to cry. So then, sometimes I don't know what I'm going to see when I walk in, but it just seems like every time I open a door, like I can, I know when they say she's angry, I walk in and it's, an African-American woman. And when she's anxious or she's gonna cry, it's typically a white woman. And I say this because we also need to diversify the representation in healthcare when it comes to ancillary staff, like not just doctors, but the patients that are getting, the people that are getting your images, the people that are greeting you at the front desk, the people that are getting your ultrasound, your blood pressure, because even their demeanor can reflect on how you receive your doctor. And you may already go in there like nervous, and your nervous may reflect as anger, which will then, in return, you may not get all the information that you need to get in when it comes to your care.
Oh.
So I think the part on the community, what we need to do more, African Americans need to normalize the conversation about their family history. You know, like you need to ask your grandmother, ask your mom, who had cancer in my family, who has diabetes, or like just how is the health of the family?
Exactly.
You know, so then you know when you go on your doctor's appointment and they ask you, do you have any family history of cancer, hypertension, any of these things, you can tell them, which then should flag them to say like, okay, so maybe we need to get them to see genetic counseling, or maybe we can monitor them closely. Another thing that all women need to do, please get your mammogram starting at 40. That is so important. There's so many guidelines. I could say the United Task Force for Preventative Medicine says 50. That is wrong. That is so wrong, and it's very wrong, and they need to change it. But the American Cancer Society, the American College of Radiology, Society of Breast Imaging, all advocate for 40, and 40 is the age to start your mammogram. And then when you get your mammogram and you get that letter that says, you know, you're okay, we don't see anything, but this is your breast density. Know your breast density. They'll tell you whether it's dense, heterogeneously dense, fat, or scattered fibroglandular tissue.
Okay.
That means something. And if you don't know, you can call, you know, or when you go to see your doctor, ask them to explain it to you. But dense breasts make it hard for us as radiologists to read between your dense breast tissue to find masses. And that can reduce the sensitivity of the scan. So that would allow you to get other imaging. We can do a mammogram with ultrasound or a mammogram with MRI. But if you don't know your breast density and you don't advocate for getting other supplemental imaging, we could be missing cancers. And it's been proven that you can miss cancers. Another important thing is, like I said, knowing your breast. If you do feel a lump, if you do have breast pain, if you have abnormal nipple discharge, go see your doctor. Don't just say, oh, it'll go away. I'm gonna just wish it away in a month, because most of the time it does, but a majority of the time it doesn't. It could be cancer. And we see a lot of people that just say like, I felt this lump months ago, but I was too scared to see my doctor. Like, don't be scared. We are here to help you. So like going and seeing your doctor and then getting that mammogram, you know, we could have saved, you know, I don't know, 10 years of your life by just seeing something 2 months earlier. Because again, things are more aggressive in African Americans.
When I turn 40, I'm coming to see you, okay? So just make room. Thanks.
No problem. And lastly, we just need to advocate. Black women, we need to advocate for ourselves. You know, talk to your family, tell your mom about the mammogram, tell your girlfriends, you know, when you're having your wind down with your friends, you know, I know it's not like the funnest conversation to have, but just making sure that people are getting their mammograms. I had one patient that said she was on a 3-year plan. And I said, what is a 3-year plan? And she said, well, I get my mammograms every 3 years. And I looked at her and I was like, there's no guideline in the world that says that. And she was like, well, I'm glad I came because you caught my cancer early. And I told all my girlfriends, and now they're all going to start getting their mammograms every year. So just small things can change somebody's habit when it comes to their healthcare and, you know, make things better for them.
Thank you so much, Dr. Jackson. You coming back for a part 2 as well?
Yes, I'll be back.
Okay. Alumna Brooks, you coming back too for a part 2?
I am definitely coming back if you invite me. Definitely.
Okay. All right now. Okay. Well, thank you so much, Alumna Dr. Jackson, for your best practices and your keen awareness. And as always, thank you for your service. I mean, we need to write a green book for the medical field, you know, for African Americans, because I mean, you guys are just dropping straight gems that I had no idea about. And I'm sure some of our people that are older and that are younger, you know, have no clue as well. So this is awesome that we are covering these items. I know we can't cover them all within an hour, but hey, we could do 3-part series. So that'll be awesome. If you all have any questions for Alumna Dr. Jackson, please type them into our Q&A box in your Zoom control panel now, and we'll be sure to get to them during our Q&A session. All right, now, last but never least, introducing the fire that's about to come. Our final panelist for this afternoon is Alumna Dr. Trelunda Triplett. Alumna Dr. Triplett is celebrating 24 years of service as a co-owner and director of operations for the Institute for Successful Leadership Incorporated. Alumna Dr. Triplett leads ISL's drive to foster comprehensive wellness, not just the absence of disease, in diverse populations across the lifespan and around the globe. Alumna Dr. Triplett completed undergraduate degrees in business administration from Clark Atlanta University and industrial and systems engineering from Georgia Tech. She is honored as the University of Michigan Bridges to the Doctorate Fellow, McKnight Doctoral Fellow, and Distinguished Alumna of the University of Miami Leonard M. Miller School of Medicine, where she earned her Master of Public Health and Doctorate of Epidemiology with specialty in public health ethics. Heal the people, heal the world. Alumna Dr. Triplett currently resides in Orlando, Florida, and enjoys international travel, live music entertainment, and basketball. That's what keeps her looking like she about 13, but that's good. We're gonna get some of that healing today as well. How are you doing, Dr. Triplett? And thank you so much.
Extremely well. I thank you so much for having me, and I bring you greetings from sunny Central Florida. And I want to send a special shout out to my colleagues and classmates of the illustrious class of 19. And it is such a pleasure to be with you all today. It certainly is.
Thank you so much. Well, we're going to go right into your question for today. How about that?
Fantastic.
Yes.
Fantastic.
So why does racism, both intentional and unintentional, affect the health and well-being of individuals and communities and stifles the opportunity of many to contribute fully to the future and growth of this nation?
Well, I want to re-highlight and confirm everything that the rest of the panelists today have brought forth. The incidence of systemic racism, the influence and impact on quality and access to care, on housing, on employment, on various facets of our lives has come directly from the influence of racism. But I want us to also be clear about what racism actually is. Racism is discriminatory practices and attitudes on a group of people based on what you see. Mm-hmm. Now, we've heard us referred to as Black. We have heard us referred to as African American. Let us be clear, African American is an ethnicity, not a race. Mm-hmm. Okay? Race is so insidious because if you look at me, do you know whether I'm from Gary, Indiana or Port-au-Prince, Haiti? Race cannot even tell you what language a person utilizes. That's why it is so insidious, and it so influences the quality and access to care, and therefore it influences those social determinants of health, which along with individual behaviors can influence our risk for particular health outcomes. So I want us to be very clear about what race is and what race is not. And I think that Dr. Jackson was very clear about different curricula as far as medical schools are concerned. They are very unclear about what race is and what ethnicities are. And as an epidemiologist, it is absolutely my pleasure to disaggregate that data and be clear about who it is that we're talking to when I develop behavioral interventions, when I develop these type of interventions to address this systemic racism that we see and its influence on every aspect of our lives. I need to know who it is I am talking to. So to say Black is not enough. What if they speak French? Mm-hmm. And I walk up to them and speak English because that's what I'm comfortable with. I have missed an entire population of people because I made an assumption. So let us be clear about that. Now, as far as racism stifling our influence and what we're able to do in this world, racism is not new. It is not a novel concept. So what we are here to do, let me just speak to my scientists in the room right now. You all heard that I'm also an engineer. Every action has what? An equal and opposite reaction. And so racism influences and impacts those who endure it, as well as those who present it, who believe in that, who exercise those kinds of attitudes and behaviors against people which they know nothing about. So when we talk about stifling what we are here to bring, we are a noble and intelligent group of people. I'll use Dr. Kirsty McMullen's word, we are genius. And what we are here to bring, nobody can take away from us. What is truly for us is for us. And we will continue to contribute that which we are here to do when we recognize our own value and our unparalleled contribution to this world and where we live. So that's that.
If you dropped the mic on that one, you know, I was still listening for more, you know.
Absolutely. We got part 2 coming. We got part two coming.
Yes, I do. Yes, we do.
Absolutely.
Well, Dr. Triplett, tell us more about the Institute for Successful Leadership Incorporated, signature approaches, you know, towards addressing individual and group level risks to promote lifelong wellness.
Okay, I'm going to be very quick about this. What we talked about before when we talked about racism and social determinants of health, that is only one source of health risk. The other source is individual behaviors. So do I smoke? Am I exposed to tobacco? Okay, the social, cultural, environmental factors that might influence my risk. Do I know somebody that smokes in my face? Do I go to hookah lounges? Don't make me start pointing fingers and naming names. Secondary smoke exposure is real. And so whether I smoke individually or not may not influence my risk at all, but the combination of my exposure to tobacco use can influence my risk for lung cancer, whether I personally smoke or not. The Institute for Successful Leadership, our signature approaches address both those individual behaviors and those socio-cultural and environmental factors at the same time. And so one of the things that we also do is we build and encourage leaders from diverse sectors of communities to become health leaders, to become knowledgeable about what health messages are out there and how they can improve the health and well-being of the people to whom they have access. And so we not only initiate the necessary changes that are necessary to change the outlooks and health status of communities, but we want to sustain those changes over time. So we revisit, we make sure that leaders are in place. We make sure that technical assistance and capacity building and making sure that people know what they need to know so that they can share it with communities and build that social capital. So that is our signature approach, and it has been one that has carried us for 24 years, and it'll be 25 in March. So I'm very, very happy about it. And as a scientist and as a person and as a human being, I am glad to be a part of a group of folks that are committed in this way, and also people who do not lack the ethics to make sure that we do the right thing the right way with the right people. Amen.
Amen to that. Well, thank you so much, alumna Dr. Triplett, for breaking it down and for definitely bringing us your awareness. If you all have any questions for alumna Dr. Triplett, please type them into our Q&A box as well in your Zoom control panel right now, and we'll be sure to get to them during our Q&A session. Thank you all to our alumni panelists for the insightful gems that you all have released today to go forth with our attendees on this call. We will go ahead and take some time for questions now. Although it is 1 o'clock, if you all can bear with us for about 5 more minutes, we do want to get some of these questions answered. And the rest of them will come to your emails individually because we want to ensure that your questions are answered. So just as a reminder, please be sure to type your questions into the question box in your control panel. So now is the time to definitely engage and network with your alumni. Let's go and see what we have, because we definitely have some. So the first question is for the alumna Brooks. This is from Lawanda Holmes Williams. She said, do you think that COVID has helped to put a spotlight on the health disparities in our communities?
Definitely. I think, and COVID, the presence of social media, the way information is spreading so rapidly, people have been exposed to more information they're typically exposed to. So it's very interesting to hear people say, oh, they have comorbidities, they have hypertension, they have diabetes. We've known about these comorbidities for 30 to 40 years, but I can say now with the pandemic, it has brought it closer to the forefront.
Exactly.
So we need to use that for a positive.
I agree. Next question is for alumna Dr. Jackson. This is from Hakeem Hicks. He says, what are some ways that you all recommend supporting or caring for Black patients who are shy away from going to the doctor because of lack of finances or resources?
I think one of the important ways is to get other family members involved in advocating for their care. If you feel like your mom or your grandmother or someone very close to you needs to get there, volunteer to take them, volunteer to go with them, volunteer to ask them in advance when you're at home in a comfortable environment, you know, what are some of your concerns so that you can address the questions for them. And then, you know, advocate for them to ask more questions and do more research and just be their supporting system to get them out there. I think also in the community, normalizing seeing the doctor in church, you know, talk about when you're going to see your doctor and what kind of issues are important. Maybe have them come to church and, you know, be there in a community in a comfortable environment where they can explain to you what the important of X, Y, and Z issues are, or these health issues, and how do you want me to help you? Like, you know, ask them how I can help you, not just throwing on what you think that needs to be done on their end, because sometimes a lot of people take offense to that. So when you work with them as a team and you come up with a plan and they agree on it, then it's easier to get people to come out to address their healthcare issues.
Exactly. Thank you, alumna Dr. Jackson. And ladies, while each of you all are answering your questions, can you all also drop your contact information in the chat, please? So whichever you would like to share with our attendees that are on the call today that would love to reach out to you, please drop your information in the chat now. Our next question is for alumna Dr. Ayanna Kersey McMullen. This is from Chelsea Scarlett. She says, thank you for answering my question. I appreciate your time and confirming what I am doing. It's unfortunate that I have to, oh, never mind. She was responding to you. Sorry about that. Let's go, please. Hold on one second.
I actually answered a few questions already in the box. I don't know if you just want to just read the answers, or because I thought there were a few questions that were really very important. Chelsea asked a question about how do Black women advocate for themselves in the healthcare setting, which my answer is there for anyone to read. But there was actually one that I thought was important that I hope that you'll allow me to kind of speak to a little bit, and that was from Hakeem Hicks.
Okay.
So he asked a question about, you know, we understand that Black people deal with many complications, but he asked specifically in the context of the LGBTQ community, and what can they do as future health practitioners to address healthcare for that demographic? And I'm really glad that he asked that question because issues that affect people in the LGBTQ community are not well addressed in the general medical population, but particularly within our community as well. And the answer that I gave to Hakeem in all transparency was really starting with myself and identifying the things that I did not understand, identifying what my own internal biases might have been, or areas in which I felt uncomfortable or didn't understand or didn't know, and to start to educate myself. I think the responsibility lies with the individual to be transparent with oneself about what you don't know. And in starting there and starting from a place of deep love and compassion for other human beings, then you will take the time to seek the information that you need. But we have to at least acknowledge that we're not having those conversations. We talk about Black Lives Matter, but it's all Black Lives Matter, not just the ones that we're comfortable with, right? And so we have to start having that internal dialogue and having those dialogues within our community, and then sometimes seeking the answers from the people that you are trying to serve. If you don't know the answer and you can't easily find those resources, how about just ask the people who need your services, right? And some of that starts with asking people, how do you want to be addressed? What pronouns do you want me to use? Not making presumptions about people's lives. And for me, I will just say the most important thing was to tap into the fact that I knew that what I really wanted was to extend love to my patients. And so that started with, if I started from that place, that I could overcome any obstacle that I may have been facing in terms of understanding how to address this population. So I think the most important thing is really educating yourself and being honest with yourself.
I agree.
I would agree. And, even when you're discussing or having a conversation with people, I write a lot. I do a lot around research and trying to tell the story that the numbers tell. I can remember one of my professors told me, don't you ever forget that the data are people with the tears brushed away. And so whenever I'm putting together a research study or telling the tale of the data, I have to recognize these are people. There's a level of respect and compassion and empathy that we have to be reminded of and understand that is part and parcel to why we are here and what we are here to do. So I can do nothing but concur with Dr. Kersey McMullen. Absolutely correct.
Awesome. And to close out, alumna Dr. Triplett, this question is from Rosalind Hill. She say, how do public health leaders create a unified effort to serve our communities? And how do we guide the future public leaders in the right direction?
That's an excellent question. And I believe that it begins with a reassessment of our ethical foundation. I think that we have gone quite some time with the three basic ethical components that have driven public health into wherever it is right now, because I am not going to sit here and tell you that public health has all the answers with respect to equity and proper care to people. I'm not going to tell you that. So as far as current professionals, we have got to reassess what our ethical foundations are. Why are you here? What is it that you are here to address in communities across this country and across this globe? And if you cannot answer that clearly and succinctly, you need to do everybody in the whole wide world a favor and get out of the way. And please don't make me tell you, because if I see you and you are out of line, I will tell you straight away, you are out of line. Now, whether it's your methods, whether it's the communication that you're bringing back to communities who were kind enough to participate in your research study, and now that you've gotten what you want from them, now they are every kind of, lazy, raggedy person you can think of, that is inappropriate. Mm-hmm. So it definitely, I believe, begins with us reassessing what our ethical foundations are, and then making that a part of every public health curriculum across this country.
Good. We do have 3 more questions left, but we will be, due to the time limit, we will be sending those back out to you all to ensure that your question is answered from the appropriate person. Great. Thank you, everyone. We appreciate you for being here today. Super special thanks to my colleagues, Senior Director of Alumni Relations, Mrs. Gaylan E. Gatewood-Josho, and to Dr. Michelle Rhodes for their stellar service, and to our phenomenal panelists for a remarkable job today. Outstanding. Thank you so much. Thanks again for joining us, and we look forward to your support and for joining us on February 11th for another snatcher up. So, we look forward to you all be here. Please also look out for more information regarding our events by following us on our social media channels at CAU, Office of Alumni Relations, or CAU Alumni Relations. You may also visit our website at www.cau.edu. And in the top right-hand corner, just select alumni and you can see what all we have planned, what all we're doing, anything that you may have missed that you would like to, look at again, or if you just would like to go down memory lane, we are there. So definitely come and see us, ask us questions, let us know what you would like to hear, and let us know what you would like to see. Otherwise, you all have a great rest of your day, and we hope to see you again on February 11th.